I'm about to point out to you. These three books, largely in the popular press, continue to describe the tension between the pharmaceutical industry and medical care. And I want to quickly summarize these three books for you to give you a sort of closure about the context of the work we find ourselves in. Well, the first book, and notice the cover, a twisted stethoscope, so even a third-year medical student could not possibly hear heart sounds trying to listen through a stethoscope like that. So Don Bartlett and Jim Stahl are Pulitzer Prize winners from their investigative reporting in other spheres, and in this book, Critical Condition, How Healthcare in America Became Big Business and Bad Medicine, what do they describe? Well, I'll just make 3 points about Bartlett's and Stahl's new book. They talk about this litany of horrible stories and hyperbole and distortion, in my view, that they say that every physician that gives out a sample of drugs to needy patients is being taken in by the pharmaceutical industry. They say that market forces in our nation, the world's largest capitalist economy, when driven into the relationship between doctors and patients, it has no place there. And finally, they recommend the creation of something they call the U.S. Council on Healthcare, the USCHC, a sort of overarching national body that would organize all the monies in the healthcare system and make the allocation decisions just like the Federal Reserve Bank does. I'm sure Hal would be thrilled for such an organization like this, just like our dean would be at Jefferson. So that's one of the three very popular titles out there in the lay press about the issues we're talking about this afternoon. The second book that I've had the opportunity to research in this area is a book called On the Take, How Medicine's Complicity with Big Business Can Endanger Your Health. Now, for the doctors in the room, you'll recognize, of course, Dr. Jerry Cassira, most recently the editor-in-chief of the New England Journal of Medicine, our flagship journal emanating from Harvard Medical School in Boston. And Dr. Cassira, let me give you 3 main points from his book. He talks about the fact that we must swim against the prevailing current. We have to find physicians who are courageous enough to publicly say, we're not going to have direct dealings. We won't be influenced by the power and the money behind the pharmaceutical industry. Dr. Cassira says that he wants all medical editors, and as Hal pointed out, since we have 4 major national journals coming from our office, we understand this issue. He wants all medical editors to have very explicit rules and regulations to prevent both real and perceived conflicts of interest. And finally, he'd like to create a national panel in the same model as we've done with the Institute of Medicine of the National Academy of Sciences. Dr. Cassira would like to create a national panel of experts to continue to examine this source of conflict between our work and the work of our colleagues in the pharmaceutical industry. The third and final book in this trilogy of woe that I've written about is also by another former editor of the New England Journal, Dr. Marcia Angel, and her book is called The Truth About the Drug Companies, How They Deceive Us and What to Do About It. And these are very provocative titles, let alone provocative material inside the books. What does Dr. Angel call for? Well, she explicitly says that the pharmaceutical industry, in essence, lies to us, that their claims about the monies they must spend to find a molecule that works, where they describe it as kind of looking for a needle in a haystack, and why there's global integration and why drugs are expensive. She says all of that essentially is a canard, just basically rumor, perpetuated by the industry. She also says, and this is one part that I think might have some truth to it, that certain clinical trials should never have been published. That's the story on the front page of today's New York Times. And her third point is, which I know will be of interest to everyone here and at our medical school, that the University Office of Technology Transfer, the beautiful multicolored newsletter that I just got from your corporate headquarters describing your Lilly Center, your Aventis Center, your Medco Center, and Jefferson has similar arrangements. All of that should be done away with, and that it only helps to perpetuate and conflict of interest, whether real or perceived. I'm sharing this with you so you'll have a sense of the power of the kinds of people, 2 former New England Journal of Medicine editors, Pulitzer Prize winners, front page stories in the Wall Street Journal and New York Times, to give you some sense of how urgent many of our national thought leaders feel this issue, the relationship between academic medicine and the pharmaceutical industry, how urgent they feel this needs reform. Here's a front page story just a year or so ago from the New York Times also, and this is fascinating because we learn in this piece about physicians who received literally tens of thousands of dollars to continue prescribing particular drugs for particular patients and to maintain their membership in speakers bureaus for companies like Schering-Plough and others. What you may not appreciate also, without having read this article, is that the pharmaceutical industry contributes more than 50% of the money for what physicians call continuing medical education, grand rounds, conferences, speakers bureaus, which we are statutorily required to accrue every 2 years to regain our licensure. And it does raise some disturbing questions about the relationship between the industry and the power and the necessity for continuing medical education. Well, finally, from a pedagogic perspective, I thought all of this really came to a head last spring when the U.S. Attorney's Office in Boston sent federal agents into Massachusetts General Hospital to subpoena pizza. That's right, to subpoena pizza, pads, and pens emblazoned with various pharmaceutical company logos from a typical noontime intern and resident luncheon. I bet today, had we walked through the halls of the adjoining beautiful hospital, either here or at our hospital in Philadelphia, we could have found maybe 5 or 10 even noontime pharmaceutical company-supported luncheons. We'll talk more about their propriety, how they should be organized, what the appropriate content could be. But in this article in Modern Healthcare last spring, I was scared to learn how these federal agents were deployed to abscond with all of the evidence, and especially the cold pizza left over from the luncheon between the medical students, interns, residents, and members of the pharmaceutical industry. So we've got a problem. And let me close out part 1 by showing you what else is going on, because it was inevitable that this problem would spill over onto the World Wide Web. Medical students, researchers, and others who were very deeply troubled by these conflicts of interest or perceived conflicts of interest have established some websites. I'm only going to show you 2. One is called Healthy Skepticism, Countering Misleading Drug Promotion. This is actually created by Dr. Mansfield in Adelaide, Australia, and I'll show you more about him later. But you could log on to here anytime, www.healthyskepticism.org. This is a most recent update just a month or so ago for you to get a sense of what's involved in these activities globally, that this problem and challenge is not restricted to the United States. And here you can learn about many of the stories that I've just relayed to you in the last 10 minutes. And finally, created by medical students here in the United States, the website called No Free Lunch, where it says just say no to drug reps, and you can take the CAGE test, which we don't have time to go through this afternoon. I think it's fair to summarize the first part of our time together by saying this is a big problem, whether real or perceived, reaching out to the heights of our scientific community at the National Institutes of Health, to Wall Street, to medical schools, to medical students, interns, residents, and attendings in all walks of life and work in our business. Now, the big question is, what's really going on? Who's right? Where's the truth? How big a conflict is this really? And now we have to turn to the second part of our time together to look at the research evidence and try to make head or tail out of all this context that I've just spent some time describing with you. So going back into my files, and this is really what stimulated me to be thinking about this issue when Hal called me back in February of this year, is a piece by Dana and Lowenstein, who are social scientists, but they're writing now in the Journal of the American Medical Association, one of our most important medical journals. And Dana and Lowenstein essentially say the following. Any gift, whether it's that pen, pad, pizza, or a check for $10,000, any gift is too big. And any gift, according to their social science research, has the power to subconsciously create bias in any physician, nurse, or pharmacist recipient of that gift. Now, when I read this in a prestigious journal like JAMA, I thought, gee, well, this means that absolutely every doctor I know is terribly biased. If I added up all the medical meetings I have been to and the tote bags and mugs and pens and pads that adorn not only my office but every office of every doctor I know, this would mean hands down from the get-go, no matter what, we're all biased. And I searched my own sense about this to really try to self-evaluate in light of Dana and Lowenstein's paper, and I thought, gee, do I really feel that I'm so biased either for a particular product or against a particular product just by virtue of a seemingly innocuous gift like a pen or a pad? And this got me to be thinking even in more detail about the topic for today, and let me quickly review with you some material from a special issue of the American Journal of Bioethics, and it was entitled All Gifts Large and Small. All Gifts Large and Small. And by the way, this special issue of the American Journal of Bioethics was sponsored by Pfizer Pharmaceuticals, the same group with enough chutzpah to sponsor today's program as well. So let me quickly outline for you some of the additional research evidence, and I'm going to let you draw your own conclusion as to where the truth is between the two ends of the argument that I've presented to you. So Peter Mansfield, again, University of Adelaide, Australia, the creator of that Healthy Skepticism website, he wrote in the American Journal of Bioethics that essentially interns and residents and medical students lack informed consent in their dealings with drug reps. Now, this is a little bit detailed, but in essence, this means that when representatives, salespersons from the drug industry come and meet with our medical students and interns and residents, we should elicit a written informed consent from every single doctor trainee to alert them to the possible biases in the presentation. An incredibly cumbersome, probably operationally impossible thing to implement, but nonetheless an important article in a serious peer-reviewed ethics journal. Sheldon Krimsky from Tufts says zero tolerance, basically like the alcohol policy in my children's high school. If you're caught, your goose is cooked. Zero tolerance, meaning absolutely no lunches, no pens, no pads, no pizza, no money, no research, no clinical trials, nothing. And all of a sudden we would have to pack our bags and say goodbye to at least 50% of continuing medical education and probably more than 80% of the clinical trials that we are so proud of in our business. Robert Goodman from Columbia Presbyterian in New York says, well, you know, in the internet age, when any doctor at any time can log on to any website to get information about pharmaceutical products, why should we tolerate the detail force, the drug reps who come to tell us about their latest products? That essentially it's an anachronistic issue. We don't need them anymore, therefore we should essentially ignore them. And finally, Naomi Seeler, writing from Johns Hopkins School of Public Health, she has some sense in all of this and says, you know, this is just a sideshow. The real issues, of course, are the 44 million Americans with no health insurance. Why are we so worried about pens, pads, pizza, and the like? And I'll let you draw your own conclusions. That's about the state of the art in the research literature about the relationship between the pharmaceutical industry and organized academic medicine. Let me conclude part two with one more article that I thought would be relevant given we're here at a great medical school like RWJ. These researchers from Wake Forest University School of Medicine in North Carolina, They asked interns and residents and attendings, just like those walking around in the hospital next door, they asked them, well, what do you know about how drugs are developed and how drugs are sold and what they really cost and how important they are? And to my surprise, most interns, residents, young doctors had really no clue how this industry worked, what the detail force was really all about, how they were paid, what the flow of funds were. And so Wake Forest did, I think, a pretty admirable thing. After doing this survey and realizing that most of the doctors had no clue how this industry really worked, they did the only thing professors could do. They created a curriculum. And they implemented this curriculum and then retested the knowledge base of all of the students, and they scored much higher in the second, third, and fourth years of this new curriculum. So what's the summary about the research evidence? Well, I'll let you be the judge. Clearly, we have a national dilemma on our hands. Clearly, there's a perception that doctors can be bought, that we're on the take, that we're the focus of public ire and consternation, given those 3 popular press books. The research evidence would argue, well, not only is this real, but it may be even deeper than we can imagine. What are we going to do about it? So let me turn then to the third and final part of my time with you and give you our sense from one medical school's perspective, what I think is a pretty pragmatic and effective and operationalizable answer to how do we manage this perception about the conflict of interest. So these are my 3 children. These are my fraternal twin, almost 18-year-old daughters. This is Leah. This is Rachel. This is my 14-year-old son, Jacob. I'm David, married to an Esther. We are all out of Old Testament names at this point. And I show you this. This is my cue that I have about 10 minutes of your attention span left. And when I think about the future, surely I think about these 3 punams, as I'm sure you think about yours as well. Okay, so let's talk about the future. Where are we going? What's the difference? What has Jefferson done? And can it be a model for the future? Well, I think Malcolm Gladwell described it beautifully, and it was great the way Ted quoted his newest book, Blink, which I think is even better than The Tipping Point. But in The Tipping Point, Gladwell says, listen, social change occurs just like an infectious epidemic. One person gets an idea, he spreads it to another, gives it to 10 more, they travel, give it to 50 more, and all of a sudden, it's gross to smoke in public. All of a sudden, social mores, habits, beliefs change. And so here's the question as we turn to the third and final part of our time together. Have we reached the tipping point in this controversy between medicine and the pharmaceutical industry? Or is it just a lot of brouhaha, or is something really good possibly going to come out of all of this carrying on that I've just described to you, both in the lay press and in the research literature? Well, let me try to set the stage for the future with you together. Dr. Jerry Cassira, or Dr. Jordy Cohn, one of our key leaders and the president of the Association of American Medical Colleges in Washington, somebody we all look up to, a former dean, major national spokesperson for organized medical school voice. Dr. Cohn says, well, you know, the real problem is we have to change the culture. And we have to change from a culture so focused on our individual needs and wants and desires in medicine to a culture focused on what he calls the population imperative, to a culture focused on teamwork, cooperation, collegiality, sublimating our individual needs for the greater good of society. So this raises a series of very important, challenging questions about the future. Here it is in a nutshell. Can Jefferson Medical College and can Robert Wood Johnson Medical School do it? Can we teach to our students and our doctors of the future to act as a team, to sublimate their own personal needs, wants, and desires for the greater good of the public they're being trained to serve? It's an awfully hard question to answer, and I'll let you ponder that on your own. Here's what I think our pragmatic one medical school's solution to this challenge, and I want to tell you about this because we're awfully proud of it. We heard Dr. Cohn say that we've got to go from this world of individualism to collaboration. And here's the question. Is this teachable? How do we create the forum to to carry on this kind of work? Well, we went back and looked at some other work, and Morty Soslin and I had studied how medical education, whether it's agile, able to change to meet the needs of a changing society, and we looked at the work of others that were involved in this activity. We looked around the country for examples of where the industry had worked effectively with academic medicine, and I'm very proud of the work. This is from Pfizer's Medical Futures Forum just a few weeks ago in New York City. Hundreds of the world's leading academic researchers from more than 100 different medical schools spent the evening in New York City celebrating their relationship, out in the open, proud of it, of the research that they had done as a team with Pfizer's monetary support and the hard work of these hundreds of doctors from all over the country, and it's a proud group to be involved with. So I started thinking, well, what could we do at an individual medical school that would sort of distill this kind of spirit of cooperation? And I want to tell you about that. We created now 3 years ago something we call JIAC, J-I-A-C. And I won't bore you with all the details. Here's a copy of the cover of our most recent meeting just this past fall called the Jefferson Industry Advisory Council. And the subtitle, Working Together in a Challenging Environment, is exactly our operational motto. Here's my pragmatic business school Wharton hat on. I said, you know, the public thinks this is a big problem. That's good enough for me. Let's bring together the principals on our territory and let's have a quiet conversation in private, no press, just us and them. And let's figure out how can we make this work, because people, whether you like it or not, we are inexorably intertwined on one another. For those clinical trials, for CME, for research dollars, there is no way around it. To say that we should just separate ourselves as though by magic and go our separate ways is silly, impractical, can't be done. And so recognizing this, the leadership of our medical school, with the explicit support of our dean and board of directors and trustees, said, okay, Nash, if you think you could do it, you have our blessing. Go ahead, invite them into the lion's den and see what will happen. And I'm here to report I still have my head, and that we have an outstanding relationship with literally scores of companies around the world who recognize the power of an open dialogue, of a non-threatening environment where we could sit down and say, listen, okay, maybe we'll make some changes. No more pens, pads, and pizza. Let's really focus on what's important to you. How can we change continuing medical education for the future? How can we create rules and regulations that make sense? So very quickly, we needed a pragmatic approach. We have a good deal in common. We have to improve the scope and depth of our dialogue together. We have to fund pilot programs to make this work. New websites, new research opportunities, less advertising, more focus on what is the scientific questions at hand. And we have to create high-quality, enduring educational materials out of all of our work together. Well, our faculty picked this up, and I'm sure here at RWJ we have similar kinds of activities, and we created a faculty committee to essentially codify the work of the Jefferson Industry Advisory Council. And again, we don't have to go through all of this together except to say we now have it approved by the faculty senate at our medical college that we're not going to accept individual checks written out to individual faculty members from the pharmaceutical industry anymore. They're going to go directly to the medical school. Then we'll reallocate those monies as each department chairman sees fit. And that's how we run our budget. That's how we're going to run these outside monies. And Jefferson Medical College will control all of the educational content. We'll make sure all the key criteria are met. I feel pretty reassured by the work of the Jefferson Industry Advisory Council, by the work of our faculty group, so much so that I've written another editorial about it, and you have that in a copy of the P&T magazine that's at your seats and that you got at the desk. I also want to tell you that we're so proud that today's meeting is going to be written up and published in Pharmacy and Therapeutics because of my strongly held belief as editor-in-chief that we've got to extend this dialogue to everybody in the business. P&T goes to 60,000 physicians, nurses, and pharmacists every month all around the country. If you're on a committee that makes a decision about a drug, you get this magazine. So we're going to take today's presentation and your feedback, and we're going to turn it into a supplement to this great magazine, and we'll be able to continue the dialogue, which is, after all, what work like this is all about. Well, let me go to the final 2 minutes together and stay on schedule and just take a step back and think about the kinds of doctors we want to train, that Dr. Paz and I are committed to for training the kinds of doctors here at RWJ and Jefferson for the future. We have a big responsibility as medical teachers and professors, and we have to explain to our medical students that this artificial separation between our clinical role and our managerial role is exactly that, artificial. Because every doctor understands, or ought to, that she controls nearly 16% of the world's largest economy. That's right. No other country spends more for health care than we do, nearly $6,000 for every